Good evening, everyone. Thank you so much for taking the time to join us tonight for tonight's discussion on long-term use of 2.5% polyacrylamide in performance horses, presented by Dr. Jason Lowe. Dr. Lowe has over 30 years of clinical experience in specialty equine clinics throughout the world, particularly in the UK and New Zealand. He first started using 2.5% polyacrylamide 10 years ago as a practitioner himself and was motivated by the need for more research in equine specifically, and has since published 3 papers on clinical application, efficacy, and safety of 2.5% polyacrylamide. Most recently in July, Dr. Lowe became the Chief Veterinary Officer for Contura Vet. And also joining us tonight is Dr. Meg Green, the Veterinary Services Manager here at Contura Vet US, and she will be helping moderate tonight's Q&A discussion. At the bottom of your panel, you will see a Q&A box. Please feel free to submit your questions as tonight's discussion moves forward, as well as at the end during the dedicated Q&A time. So without further ado, Dr. Lowe, the floor is yours.
Thank you very much, Rachel. Thank you for having me, and thank you to Contura for organising this. So I've titled my talk here Demystifying 2.5% iPAAG because I think there has been sort of a number of urban myths out there, misunderstanding or around the product. And it's such a new and exciting molecule. It does take a little bit of time to get your head around. And it certainly, I know from my own experience, it took me maybe 6 to 8 months to understand what it was doing in my patients and the benefits it was giving. So I hope, join me for this talk as we try and explain through that and look at some of the long-term safety data, which to me, there's such a strong body of evidence out there now for the benefits of this product. So I just want to start with a conflict of interest statement. As Rachel alluded to, I am employed by IMS Vet, which has recently been acquired by Contura Vet. IMS is the market authorization holder for 2.5 iPAAG in Australia and New Zealand, and I'm now also employed as Chief Veterinary Officer. Obviously, this can be perceived as a potential influence and conflict of interest. But to address this, I want to just reassure everybody and clarify that my first obligation is, as a scientist, to uphold the highest standards of research integrity and to contribute to the advancement of knowledge in a fair and unbiased manner. But if anybody does have any concerns or questions about those conflicts, please don't hesitate to reach out. So as I said, Arthrimid Vet, the 2.5% injectable polyacrylamide, which I'll refer to as 2.5 iPAAG, is manufactured in Denmark by Contura, registered as a veterinary medicine in Australia and New Zealand, quite different from those from the US audience tonight. We're understanding it comes in through the device classification. We do not have that classification in other parts of the world. So like I say, we put this through a full regulatory dossier with the authorities. So I think really to get our heads around this, we need to start by understanding the behavior and physical properties of 2.5 iPAAG. It certainly emerged as a significant innovation in equine sports medicine globally now for managing osteoarthritis in athletes. The 2.5 iPAAG, commercially known as Arthrimid, has very distinct physical and biocompatible properties that make it effective in tissue applications, and as I said, particularly in synovial joints. So join me as we explore the behavior, physical properties, and safety of 2.5 iPAAG and how it performs under load. And I make that emphasis because to me, OA is a mechanical disease, and this product is working mechanically in the joint. It's assisting or aiding or with the biomechanics of the joint. So 2.5 iPAAG has actually been around for a long time. Contura was established in around 2002 when they developed this specific technology. And it's been in the human and animal markets now for all of that time. It's a bioscaffold polymer derived from synthetic monomers. You'll see in the image here on the right that these are the raw ingredients used in manufacture. It's an acrylamide with methylene bisacrylamide and water, which are combined through this process of what's called ILX, cross-linking technology, which forms these very long chain molecules held together with a strong covalent bond of hydrogen molecules to make this three-dimensional network and scaffold. I just want to point out there that 2.5 iPAAG is not a plastic. I've heard people comment that it's a polymer, so it's a plastic. While it's true that all plastics are polymers, rest assured that not all polymers are plastic. This is a highly water-absorbent hydrogel. Okay. So as I said, polyacrylamide is not acrylamide either. Polyacrylamides actually have their own CAS number. It's its own distinct chemical molecule, and it does not degrade back into acrylamide. And what's really cool about this molecular technology is it has very unique biological properties. It's a highly porous structure with just the right and appropriate pore size that facilitates cell migration and tissue integration. And it's that biocompatibility with tissues across multiple species, humans, goats, rabbits, equine, canine. It just seems to be this very unique molecule with those unique properties. Again, these properties, as I said, come about because of the carefully controlled manufacturing process used by Contura. As I said, we end up with just the right pore size for tissue integration and biocompatibility. Higher concentration hydrogels, you'll see 4%, 5%, 6% products there. The higher concentration of polyacrylamides have slightly narrower or smaller pore sizes, so they're a little bit more prone to fibrotic reactions and granulomatous type reactions, whereas the 2.5% just seems to be just right for tissue biocompatibility. We have very homogeneous pore size with this product. So again, a very regular molecule. This is manufactured under very strict conditions, which give that high quality in the product. It's very stable. We don't want this stuff degrading. It's temperature stable, which is useful for shelf life, useful in a practical sense in medical applications, in the back of a vet truck and out in the real world. But it's also very stable in situ. Okay, so once it's integrated into body tissue, we don't want these breaking down and migrating and moving around. It's also very important that we have the right elasticity modulus on a hydrogel product. It's these viscoelastic properties that allow it again to function alongside and in synchrony with the body's natural tissues. And so the release specifications on the 2.5 iPAAGs sit around that 35 to 120 kilopascals, and for arthrimid usually sits around the 75 kilopascals. So as I said, that's highly biocompatible. It's non-toxic. This is chemically inert substance. As we said, it doesn't break down into acrylamides or toxic products, and I'll show you some of the research around that later on in the talk. It's sterile. Again, really important that we have a sterile product that we're going to use and inject into animals' joints, human joints, human soft tissues. You don't want to be adding antibiotics to this. There's no need to. You don't want to add silver ions and things like that. We're very assured of the quality and release specifications. It's also important to point out that this product is fully permeable to organic molecules and organic compounds. Okay, so it doesn't harbor infections, it doesn't interfere with future joint interventions, other joint interventions, it doesn't act as a nidus or focus for infection. Uh, so again, I've sort of heard people say, "Oh, I've had 2.5 iPAAG in the joint, it means I'll never be able to put anything else in there." That's simply not true. Or what happens in the future if that horse has a penetrating injury or an iatrogenic infection into that joint that's had 2.5 iPAAG in there? Uh, that's not going to be a problem. It doesn't even stay in the joint. It gets integrated into the synovium membrane. And again, we'll talk about that in a minute. But just be reassured that this is fully permeable, so it doesn't alter the pharmacokinetics on other substances. As I said, the Contura factory is GMP certified, so that's good manufacturing practice under the European Medicines Agency. That's part of their compliance requirements to enter into the human medical markets. It's also a prerequisite for us to market that in Australia and New Zealand as a registered veterinary medicine. And what it means is that there's a massive amount of quality assurance auditing that goes on a very regular basis by the authorities to assure everybody that this is the highest quality product that it can be. And the specific 2.5 iPAAG formulation, as I said, with a very specific molecular weight and cross-linker content, is produced in the factory by controlling and regulating that manufacturing process very tightly. The polymerization temperature, the gelation times, the degree of purity and the ingredients that go into it, things down to the humidity during the manufacturing process. Like I say, to get a very consistent, homogeneous, regular, sterile product that gets released out into the market. So I just wanted to quickly show some scanning electron microscopes because I always find it useful for people to have a visual impression of what this gel is. It's a physical, uniform, three-dimensional scaffolding structure, non-degraded, and it gets fully integrated with the host tissue. So top left on the inset images there is the raw gel, just showing that lovely regular pore size that we talked about that just seems to suit body tissues for cell migration, tissue integration. And then these other images showing the tissue integrated gel with the collagen fibers, and we even have a cell there sitting on the gel. So how does 2.5 iPAAG behave under load? Again, a very interesting concept to sort of get our heads around, I think, as veterinarians and scientists. So research has shown that the stiffness of polyacrylamide gels significantly impacts their biological behavior. Stiffer gels actually tend to prime macrophages towards a pro-inflammatory phenotype with impaired phagocytosis. Okay, whereas the softer and medium stiffness gels, so around the 88 kilopascals, promote an anti-inflammatory, highly phagocytic phenotype in these macrophages. And this property is crucial for the 2.5% iPAAG that sits around 75, 80 kilopascals, which needs to balance providing that mechanical support while minimizing inflammation. Okay, so while the body treats this as a foreign body and macrophages will attempt to phagocytose it, it doesn't set up a fibrous or granulomatous type reaction because of that softness and elasticity in this specific hydrogel. As I said, 20 plus years it's been manufactured, specific physico-chemical properties critical to 2.5 iPAAG's performance in medical applications and its ability to integrate with the tissue without causing adverse reactions. It doesn't cause fibrosis or granulomatous reactions. It's a registered Schedule 4 vet medicine in Australia, New Zealand, and in the UAE. And on the basis of that, it's used under the Cascade with special import license in the UK and throughout Europe. The same 2.5 iPAAG technology is now used in human medical applications throughout the world. There's Aquamid in tissue reconstruction, soft tissue surgery, cosmetic surgery. Bulkamid, the urethral bulking agent for stress urinary incontinence in older women. And arthrosamid, which is now used in human osteoarthritis. So globally, there's over 1 million doses almost a year being used across multiple species and multiple applications inside joints and soft tissues. So I think it's fair to say that if there were long-term issues with safety, we would absolutely have expected something to flag by now. Again, under EMA regulations, Australia, New Zealand regulations, pharmacovigilance is an important component of any product used in the medical industry. There's a duty of care to report incidents, and we just don't see a high number of incidents with this product. So I think we can be very comfortable that nothing's flagging up. But let's dig a little bit more into the science on some of that and some of the clinical evidence to support that statement. But before we go there, I just wanted to revise the anatomy and physiology of the synovial cavity or of the joint, the synovial joints. So the joint capsule itself that surrounds our synovial joints is made up of two layers, the stiff sort of fibrous joint capsule lined by the inner layer of synovial membrane or synovium. The synovium itself is made up of two layers, the intimal cell layer on the facing the joint and the subintimal layer underneath that. The intimal layer is largely responsible for the content of the synovial fluid. It's typically 1 to 4 cell layers thick, and you'll see that in this inset image, top left here. And this is a mixture of macrophages and fibroblasts. The type A macrophages, which are mostly there for phagocytosis, cleaning up materials. The type B synoviocytes, more fibroblast phenotype, which are there for protein secretion. And then we have these intermediary cells, these type C cells that sort of move between these two different phenotypes. In fact, it's probably more simplistic than it actually is. In human medicine, they've now identified up to 9 different phenotypes of synovial tissue macrophages, say moving through from pro-inflammatory to pro-resolving. And they play a very important part in maintaining the homeostasis of the joint. What's also really interesting and critical to understand is that the intimal layer has no basement membrane. Okay, so it's merely sort of supported by the subintimal layer, which is made up of fibrous areola and fatty tissues, and certainly quite full with a vascular blood supply and nerve supply. And so essentially the synovium is sort of this membrane that filtrates the blood, and synovial fluid itself is often just described as a filtrate of the blood as the fluids will move through into the synovial cavity. But it also works vice versa. Okay, so the synovial cavity products can move from the synovial cavity back into the synovial membrane itself. And that's what happens to the 2.5 iPAAG. Okay, so we inject it into the joint. And again, just picture that this isn't a big blanket of gel that completely lines everywhere. This is lots of tiny fragments of gel which have been cut up to allow it to be injected through a needle and inserted into the joint cavity. And then over a period of around 2 to 14 days, it literally sort of sinks through or gets absorbed and integrated into the subintima. As I said, because that intimal layer has no basement membrane. So again, these are some lovely histology slides that we published earlier this year in JAVMA, which show this beautifully. So over 10 to 14 days, the gel is now sort of sunken into the subintimal layer, with the intimal cells reforming over the top of the outside, over the top of the reforming facing the joint cavity. And the gel is now sitting beneath the intima and the subintima, and that's just a natural process, right? The body will naturally try and remove these particles from the joint cavity. And if we just zoom in a little bit more and increase the magnification, we'll see the blue gel in the subintima uh, holding and supporting this sort of network of fibers and macrophages. So the macrophages have come in a low-grade inflammatory response and in an attempt to phagocytose the gel, because the body is treating this as a foreign body, but it's a very low-grade macrophage-driven response. And over time, the macrophages actually become frustrated because the molecule itself is too big to phagocytose, that they can't get their cytoplasm around it. And then over time, the body actually realizes, well, it's not causing any problems. It's just sitting there and augmenting my synovial tissue, so I'll leave it alone. And that's well documented in human medicine and tissue implants and in urethra, breast implants in women, etc., where this product is also used. So again, really important. There's no granulomas form with this product. There's no neutrophils coming in. It's not an acute inflammatory response. It's just a low-grade foreign body response. Again, very well documented in tissue implant and device applications in human medicine. And there's no fibrosis. Okay, this doesn't build up a fibrotic reaction in the synovium either. So again, as we understand that, and we move through then and look at just the synovial joint anatomy and physiology, and just going back to basics, I guess, as an attempt to sort of start to explain how this product is working to improve lameness outcomes. The two primary functions of a synovial joint are simply to enable efficient movement and transfer load. Synovitis is now well recognized as one of the single most important factors that contributes to the pain of osteoarthritis, because it's a source of inflammatory mediators, right? And that's what pain is. It's a response to tissue damage, and these inflammatory mediators are released to let the body know about that. The cells of the synovial membrane are responsible for the production and health of joint fluid. We all understand that. And good quality joint fluid will provide cushioning, reduce friction, and nourishes the cartilage, the signs of a healthy joint. But if these cells become overwhelmed, then the synovial membrane becomes the source of pro-inflammatory catabolic products, which in turn lead to that progressive change that we see in degradation of the OA complex. And again, I think we understand that it's impaired biomechanics of the joint that really sets off this chain reaction of pathologic events which lead to OA. So what do I mean by that? Well, what we're talking about is in athletic and young horses, synovitis and capsulitis, is those biomechanical changes that occur early on in the disease process and are assumed to be associated with repetitive trauma. Osteoarthritis can literally be described as the failure of repair caused by excessive mechanical stress. I think that's again well documented. So this etiology originates most often from overuse, conformational problems, predispose the horse to the inappropriate biomechanical forces on the cartilage and on the joint itself. Synovitis is a single important factor that contributes to the pain of OA through joint effusion, swelling, capsulitis. And this is activating the mechanoreceptors in the joint and results in direct chemical stimulation of the nociceptors. And again, I've just got a schematic representation of that on the right here. Just looking at that, a normal sort of initial trauma insult that sets things off, causing direct tissue damage. Then we get the mechanoreceptor activation. This can result in the chemical release of cytokines, which will also activate the nociceptors. And this is the general inflammatory response, right, which is indicative of tissue damage. And will start to cause pain in the joint. Again, release of cytokines, more swelling, effusion, and then the joint ends up in this catabolic state. Okay, it can't keep up with itself. The tissue damage is happening, and we end up in this vicious cycle of where it's catabolic, and we develop this sort of hyperalgesia, hypersensitivity, in extreme cases, even allodynia, where just this wind up of pain in the joint. So the goal of therapy, any therapies that we're using for OA, is really designed to try and restore joint homeostasis. Yeah, I think the body naturally wants to heal itself. It doesn't like being angry with itself and painful. It wants to heal. And I think in joints, because of various reasons, and obviously ongoing repetitive trauma because we continue to exercise and use our limbs, that it just continues this cycle, which ultimately leads in degradation of cartilage, which becomes that end stage OA complex. So how is 2.5 iPAAG working? Well, as was sort of described earlier, that we've injected it into the joint, and all these tiny fragments of 2.5 iPAAG are spread throughout the joint and adhere to the synovial membrane, sort of bond onto the, or sort of attached to the intimal layer of cells, which is macrophages, because they treat this as a low-grade foreign body response, and they sort of wrap around and try and adsorb and remove that molecule from the synovial cavity. And again, remembering, because that intimal layer does not have a basement membrane, the cells migrate and form around the gel, and the gel ends up translocated into the subintimal space. A process that takes around 10 to 14 days, probably happens sooner than the 2 to 4 weeks that we've set on this particular slide. Again, this is very well documented now in 2 different studies which supported the findings. So it doesn't sit free in the synovial cavity, it's completely adsorbed and will sit under the intimal layer in the subintima of the joint capsule. So again, if we go back to basics, osteoarthritis can be described as a failed repair of damage that has been caused by excessive mechanical stress on joint tissues. So the primary mechanism by which the 2.5 iPAAG operates is a reduction in joint capsule stiffness. Okay, and I'll show you the studies around that. Because it's biomechanically supporting the subintima and the joint capsule, so the synovial membrane and the joint capsule. Biomechanical support. It's a viscoelastic hydrogel with very a high content of water. Water itself is quite incompressible. It's very strong. When you belly flop into a pool, you end up red and sore. Water is very, very strong. So a tiny amount of polyacrylamide strands, 2.5%, 97.5% of this is water molecules, which are now sitting in the extracellular matrix, if you like, of the subintimal space. So it's changing the biomechanics of the joint capsule. So in disease, stretching of the synovial lining through repeated hyperextension produces pain and inflammation, and it predisposes the joint to injury. Fibrosis, really well documented now in human medicine. Fibrosis occurs in the articular joint progression of OA and plays a critical role in OA pathogenesis and progression, and ultimately, as we said, cartilage destruction. So joint fibrosis is characterized by the excessive accumulation of connective tissue, eventually contributes to joint stiffness that results in intense pain during joint movement. Okay, so pain and inflammation, biomechanical stresses, joint gets capsulitis, synovitis, joint gets stiff, wind up of catabolic enzymes, causes further tissue damage, starts to cause cartilage damage. We're into a degenerative process. Okay, so if we can support the natural biomechanics of the joint by adding something like this into our treatment protocol, we're helping restore that joint function. So improving the joint capsule elasticity and its natural function. In time, the quality of the joint fluid is also improved and its ability to act as a lubricant. So essentially, we're supporting the biomechanics of the joint. That subsequently improves the physiology because that's what the body wants. It just needs that support to do it. And we support the physiology of the joint. In turn, we'll get an improvement in the biology of the joint. So joint fluid quality will also improve overall joint function. We'll return to a state of homeostasis, which is where it wants to be. We've probably got a little bit of further studies to confirm some of that changes, and that's underway at the moment at CSU, and Meg may well talk to that shortly. But it's that subsequent reduction in tissue wear and improvement in joint function with using a product that, like 2.5 iPAAG, that disrupts that cycle of OA and restores the joint to homeostasis. So again, this is an interesting little study done by Aziz Nibar in 2017 that showed the increased load transfer capacity of the joint. It was an OA goat model, an induced OA goat model. But if we just look quickly at the slides here, the graphs on the right-hand side here. So the top line there, the teal colored line, is a normal joint. Okay, so that's literally some joint capsule resected, put between two pulleys and stretched, and it obviously reaches its breaking strain and ruptures. And underneath that in the grey line is a joint that's suffering from osteoarthritis. So it's fibrotic. It has reduced elastance, and it can't handle the same amount of tensile force going through that joint capsule. So it ruptures much earlier. And what we should be looking at here is the area under that stress strain curve is really the measure of the elastance or tensile strength. Strictly speaking, not quite elastance either, because elastance is a different physical property and more relates to the slope of these stress strain curves. But I think for the want of understanding the basics of how this is happening, it's probably not bad terminology. And again, the graph underneath, this is an arthritic joint that's been augmented with 2.5 iPAAG, and you can see that the stress strain curve is restored to normal. Again, that area under the curve is what we're looking at there. So I guess, yeah, to move forward then into the next bit, we've got sort of 10 minutes left in the presentation before we move to Q&A. So I guess the questions people ask around this product, and legitimately so, this is great. What if it's blocking pain by just killing the nerves? Like I can assure you it's not. And I'll show you the science behind that shortly. And as I said, this is a very stable product. It doesn't break down into acrylamides. Acrylamides are highly neurotoxic. They cause demyelination of nerves and horrendous things, but that's not what this product does. So is it blocking nerve transmission? Is that how it gives us the efficacy outcomes that we see? Well, Well, it can't block a nerve. It's chemically inert. It doesn't bond to receptors. It doesn't act as a drug and suppress cytokine levels like biologics are trying to do, or like steroids do, or non-steroidal anti-inflammatories. Um, so it's not how it's acting. But what if it's numbing the pain then, or and impairing that relationship between the mechanoreceptors and the nociceptors um, that are naturally there to enable the body to modulate pain, right, through the transmission of neuropeptides, including the likes of substance P. Well, my argument for that, or the consideration, I think we need to understand that pain is caused by tissue inflammation, right? Pain is a clinical outcome from that inflammation and damage. So if we were numbing the nerves and the body couldn't feel them, then if that animal was still performing and galloping and inducing trauma onto those ends, wouldn't we see a continuation of that tissue damage and inflammation? And certainly, if the joint couldn't then perceive pain, it would be prone to exceeding its physiological limits. The joint capsule, the periarticular tissue, subchondral bone, ligaments, cartilage, it would be exceeded. So we would expect injury rates to increase, right? We would expect tissue damage to carry on, and for animals to hurt themselves and the progression of that disease. So what we really need to do there is look at long-term follow-up for the evidence of the safety. So next part of my talk, we'll look at some of the evidence, okay? So we have done both in vitro and in vivo studies designed to generate data on the safety of 2.5 iPAAG to support regulatory submissions to multiple jurisdictions globally. And I guess the beauty of this molecule is that most of our current OA treatments were focused on reducing symptoms, right? As I said, non-steroidals and steroids are very much just pain suppressors. They're potent anti-inflammatories. But really what we want with OA is something that would restore joint function, restore the physiology of the joint, actually help modulate that disease process and try and disrupt that vicious cycle of OA and hypersensitivity that we get into. And so we'll run through some of the multiple studies that have shown 2.5 iPAAG is safe for animals and in humans. So firstly, some in vitro studies. Potential cytotoxic effects of arthrimid have been independently analysed with a cell growth analysis, what's called BCA staining. The methodology employed in this manner of cytotoxicity testing represents one of the easiest methods for the analysis of the detrimental effects of substances, and cell culture techniques allow rapid yet sensitive diagnosis of the biological reactivity of diffusible components of materials. This is a very common study done for medical device applications. Okay, it doesn't release toxic substances which could damage the cells. And it's used to predict the cytotoxic or necrotic effects of medical devices. And there's very good correlation in animal experiments and a very high sensitivity. So under this testing model, no cytotoxic substances are released from 2.5% iPAAG. Monomers of acrylamides are known to be neurotoxic to animals and humans, whereas polyacrylamides are non-toxic. So again, Contura has looked at the possible toxic effects of residual monomers from manufacturing. They've been calculated using recommendations from the US Environmental Protection Agency, and levels do not raise biological safety concerns, either in data-derived or worst-case scenarios. The European Medical Agency has also looked at this product and likewise ruled that 2.5% iPAAG is considered as not falling within the scope of regulation with regard to residues for veterinary medicinal products. So again, all this is a testament to the quality of manufacturing that Contura employs around its 2.5 iPAAG. other independent studies, acrylamides would be capable of producing an axonopathy by transection of neurons, that portion of the axon which is separated anatomically from the nerve cell body, and myelin. So it causes demyelination, okay? So NEBA 2017 assessed the presence of nerves in the synovial membrane in response to 2.5 iPAAG. In treatment groups, nerves were seen in similar patterns as those in control groups. Nerves were intact with normal morphology and in normal numbers. Again, this highlights no neurotoxic effects. Some people have said, well, you can still see the nerves, but doesn't mean they're working. Well, no, that's not true with this product. If we wouldn't see the myelin, we would see demyelinated nerves, and you can see that on nerve-specific staining for histology samples. So it's not damaging the nerves. And we are also repeating some of the studies at CSU in an equine model. We also recently performed another study to explore the dose and time-dependent effects of 2.5 iPAAG on the survival, apoptosis, necrosis, and ability to form networks of nerve cells cultured in vitro. Again, the goal of this study was to determine whether the 2.5 iPAAG was toxic to nerve cells. And this study showed that it was not toxic to nerve cells at any dose or exposure time tested. The study will go to publication later next year. And also, interestingly, a lot of stem cell research now is actually used in conjunction with hydrogels, using the hydrogel as a scaffold to hold stem cells in situ. So again, if this was a toxic product, you wouldn't be putting it with stem cells, right? So what are the in vivo studies that we have to confirm the safety? This is a list here of published studies, again, going as far back as 2012. So over 12 years in animal medicine around the safety of this product. So NEBA in 2012, multi-center perspective, 33 horses, ranging in age from 2 to 15 years, a good mix of sport horses, racing, and other horses, taken out to 6 months, combination of fetlocks and carpi joints, and a 70% resolution of lameness. Pretty good efficacy. Again, NEBA published in 2015 in multi-center. There was 3 centers in that study, 43 horses, again, aging in range from 2 to 15 years, good mix of racing and sport horses, this time taken out to 24 months with an 82.5% resolution of lameness at that time. So quite a long-lasting effect, which is really beneficial. Again, safety, good range of horses, reasonable numbers, multiple disciplines, no adverse events. Janssen in 2012, a prospective study, 12 horses, age range 4 to 14 years. Again, mostly sport horses. This was all coffin joints, distal interphalangeal joints, taken out to 6 months. Again, an efficacy of 67%, no adverse reactions. Interesting, in this study, all these horses were non-responsive to other conventional therapies, so probably a pretty good outcome given the difficulty of those cases and the multifactorial nature of coffin joint disease and lameness, right? There's other factors at play there. Andy Bathe in 2016 similarly published on a prospective study with 20 horses. These were all sport horses taken out to 12 months. Again, all distal interphalangeal coffin joint disease. Again, a 67% success rate. And then my colleague Lee de Clifford in 2019, we published a prospective study on 49 thoroughbred flat race horses in Australia. We'd examined them out to 6 months. They were actually a mixture of carpal and a few fetlocks. Excuse me. And again, that's sort of 67, 65% efficacy. So it starts to seem to line up to be reasonably consistent around that sort of 65 to up to 80% efficacy rate, which is pretty impressive. Again, and then we published in 2021 our prospective double-blinded positive control. So pretty much as good as clinical trials can get, apart from doing meta-analysis, when you're looking at the hierarchy of evidence that we need around products. So 31 horses, again, ranging as young as 2 years up to 6 years of age. These were all racing thoroughbreds. This time they were all carpi, lameness, middle carpal joint disease. And we actually showed an 83% efficacy. And this table from that study, I just wanted to put that up quickly just to show the range of animals in this study. So 3 different treatment groups. We put it up against triamcinolone and hyaluronic acid. 2 to 5 years of age, up to 6 years of age, a mix of disciplines, sprinter, milers, stayers, lameness range, all mild lameness really. There was 4 out of 5 in the TA treated group, which may explain why the TA treated group had a slightly lower efficacy outcome. 4 out of those 11 responded at 6 weeks, which was only 27%, which might be a bit lower than what we would expect. But again, low-grade arthritis, early-stage disease, a very strong study. Under our ethics approval, at these numbers, we were obliged to stop the study because we'd shown statistical significance, and we weren't able to recruit any more horses. Otherwise, we could have kept going. But a very powerful study with its blinding and randomization. So again, evidence of safety in vivo. This was a retrospective study, the use of 2.5 iPAAG in the UK, 3 different practices, 2 first opinion practices and 1 referral hospital, 310 horses, 802 joints, 343 joints were initially treated, and the rest of those joint treatments were repeat treatments into the same joint. 37 of horses, or 269 horses were followed up at 12 months, 37 of which had repeat treatments. 175 horses were followed up at 24 months, and 13 had repeat treatments. Follow-up ranged everywhere from 2 weeks to 7 years. So this is 7 years of long-term data of multiple horses, multiple joints with multiple treatments. Okay, and over that time, there were only 2 adverse events, both of which were at or near the time of treatment, and both responded to conservative treatment. There were no adverse events in any horse with repeat treatment. So again, big age range, long-term data, 7 years, repeat treatments, showing good safety. This is some early Australian data that we're looking at the moment, from 2015 to 2023, so over an 8-year period, a total of 703 thoroughbred racehorses, ranging in age from 2 up to 9 years, so as young as 2 years old. Again, all of these horses have had multiple doses and multiple doses per joint. We've had no adverse events. None of these horses have required euthanasia following 2.5 iPAAG, and these horses have gone on to race. The reasons for retirement have included gone to breeding barn, general poor performance, just weren't good enough. They've bled, EIPH. They've got worse in the treated joint, or they've suffered another injury unrelated to the treated joint. I think it's really pertinent with this data, and obviously we've got a lot more digging to do into here. But there was 1 horse in this group that did catastrophic fracture, but it had triamcinolone. Okay, so at 6 weeks pre-race, it had arthramid. It didn't respond. At 2 weeks pre-race, it got triamcinolone and then fractured at racing. So what that strongly signals to me is that the catastrophic fractures related to triamcinolone, and again, you look at the study in the top of that slide there, published in Australia recently, showing the high correlation rate between corticosteroids and fracture rates or catastrophic injury at raceways. And also the fact that if you get no response to the to 2.5 iPAAG, you need to reassess your diagnosis. Okay, so don't just carry on with these horses, but go back to square one, repeat your diagnostic tests, put all the data together and think, maybe there's something else going on with this horse. And I think having worked in Australia now for sort of 10 years with this product, our injury rates are down to 0.4, zero point 0.5 per thousand race starts. And I think in the US, you're sitting up around 2 or 3 injuries per thousand race starts. So I think a country where we have a registered product being used intelligently by treating veterinarians and understood by racetrack authorities, it plays its part in looking after and protecting the welfare of these animals. So I think it's strong. And that's just a schematic representation of the pre and post treatment performance of these horses. So we've had 84% of the horses have responded with arthrimide treated treatment in this cohort. So I guess just to finish quickly, because Rachel will be worried about my time, the take-home messages. So we do have long-term safety data in multiple species, okay? 22 years of data, millions of doses. We have safety data in old horses, and we have safety data in young horses, and we have safety data with redosing, repeat dosing, top-up dosing, whatever we want to call it. We have extensive research and clinical evidence from multiple in vitro studies. We have published clinical studies, and we have retrospective data analysis. It's the unique physical properties of this product that helps manage synovitis and capsulitis and fibrosis, restoring the joint function and disrupting that harmful cycle of OA, and makes it a really valuable tool in equine sports medicine. And I'm not saying this product treats every lame horse that you'll have through your clinic, but I know how it changed my practice, and I talk to enough veterinarians every day in my role now to understand how it changes their practice. And I get enough feedback from clients to understand how it affects their lives as well. So this is something that if you're not using it, you should be. and once you get your head around understanding what it's doing, it's a really valuable tool in your treatment box. And make no mistake, there's extensive research, clinical trials supporting its use and that highlight its efficacy and safety. And I'm pretty sure it's going to keep its place as one of the leading treatments for OA for a while to come yet. So thank you very much for your time, and I will hopefully be able to hand back to Meg, and we can have some questions.
Excellent. Well, thank you, Jason, for that very thorough overview of 2.5 iPAAG. I think you brought a lot of information to us in a short amount of time, but certainly helps us to really think about, adding something else to our toolbox if you're not already considering it. One of the things that has come up, when we talk about this particular product, and certainly in the questions that have come up, is really looking at it. And you touched on it, but I think just going and, just reading a question from Dr. Spear specifically is, can you tell us what happens in horses that require additional doses to maintain soundness? And some horses with OA are benefiting from yearly injections. And is that actually safe to do that?
Yeah, well, I think it's a great question. And I think, with, say, the retrospective data I've showed there's absolutely no doubt it's safe. I think what's happening in those horses, we've got progression of disease, right? So we've put an initial treatment in, and this is a tiny amount of product which goes in and supports the biomechanics of the joint. The animals responded. And so it goes back to exercise. That's the owner expectations. But then the disease can still progress, and we don't know all the other things that go on with that horse. It might go up a class, it might change owners, it might change shoeing, it might go and do something else, go further faster. So repeat dosing is absolutely safe. And I also, I have 2 categories of horses, right? So I'll do my initial treatment. I'll re-examine them around 4 to 6 weeks. And if I have a partial response, I know that I've sort of hit the right place and I might give a top-up dose. And then the second group of horses, I'm looking at around sort of 6 to 12 months. and taking in all those other factors around the owner expectations, the discipline, the season coming up, the campaign that they have ahead of them, physical examination, clinical examination, using my eyes and my ears and my hands and saying, does this horse need a repeat dose, or can we just sit on this and wait a bit longer? Or might I introduce something else into my treatment regime and management for that horse? But I hope I've answered the question, but absolutely repeat dosing, up dosing. We're seeing 6 to 12 months in most horses, race horses. We're repeating the dosing, maybe 1 to 2 years in sport and competition horses. But I think you just have to use your the other factors going on to think about how you're going to manage that horse.
So that brings into question something that wasn't touched on quite as much, but I do think it's key. It's a question I certainly get all the time, but I'd love to hear your thoughts too, is, talking about case selection for utilizing Arthromed. What are some things that are key standouts to you when you're looking at these horses, doing your physical exam, working these horses up? What are some key differentiating factors that say this would be an ideal candidate for Arthromed?
Yeah. Look, joint lameness, right? You have to localize the lameness to the joint. So again, physical examination, response to flexion, I find that really useful. I find if horses respond, especially passive flexion and front legs, I know I'm going to get a good response to this product. If it blocks out to the joint, I know it's a good case. And again, I guess, when you're standing in front of a horse and a client and you have all these different tools in your bag that you could potentially use, I just simply say start with Arthromed. That's sort of my go-to now. I'll start with the Arthromed, put that into the joint, and I know I just end up with a joint that's a lot easier to manage. Like that. I'm not saying that it cures everything and it's never going to go sore again, but I'm supporting the biomechanics. I'm treating the synovium and the joint capsule. And then I might address the intra-articular environment with some orthobiologics, with some IRAP or something like that later on. And again, I guess the only other one with that is if I have a severe acute synovitis, I probably will go to anti-inflammatories or cortisone first. I want to settle that joint down before I put the Arthromed in. I just feel when you've got a really, really angry, inflamed joint, you just want to settle that inflammatory response down, then put the Arthromed in, then you're sort of on that road to recovery from there.
That kind of leads us into what Dr. Vernon asked, specifically, can 2.5 iPAAG be coupled with concurrent treatments such as ProStride? And so correlating with that is also how frequently are you utilizing orthobiologics in conjunction with Arthromed?
Yeah, look, when I was in clinical practice, I probably got down to orthobiologics in 5 to 10% of my cases, again, depending on the age of the animal and the stage of disease and what I thought was going in. I talked to colleagues in Europe, they're just using Arthromed for everything and they're not having to combine it with other products. But I think, I think it's definitely, it can be combined. I sort of wonder in my head if that's maybe where we'll end up, is using the combination therapy. But again, I just come back to, I start with the Arthromed, I assess the response to that, and then I'll top up with other products. And I like orthobiologics when I'm in the middle of a competition season, because Arthromed, the 2.5 iPAAG is going to take 2 or 3 weeks to work. So if you've got a big competition coming up a week out and you've got a horse that's got an effused joint and it's sore on it, then reaching to 2.5 iPAAGs wouldn't be my go-to at that stage. I'd be going to an orthobiologic, perhaps with some systemic non-steroidals, cold hosing, icing, exercise, change in training to try and get it to the event.
Okay. So we have a case example that's been brought up that I think would be good to answer. This particular doctor, Dr. Nib, I have 4 to 5-year-old large 18-hand horses. They have some hock effusion, RADs are normal. They have always been resistant to cantering. Would it behoove them to have this product injected?
I would block it out to start with. I would put some local anesthetic in and just see if you get a response to that. Then yeah, by all means, it's indicated. Talking the effusion in the tibiotarsal joint or lower hock joints, or
It just said hock effusion specifically. It didn't say specifics as far as the actual joint itself in the question.
yeah, yeah. So again, tibiotarsal effusion, large horses, whether that's again, is it just a low-grade synovitis? Again, diagnosis by treatment, right? There's certainly no harm, I don't think, in trying and seeing what response you get. But it's a bit hard to know without. I'd probably be inclined to run some more diagnostic tests and perhaps put some local anesthetic in, or even combine some local anesthetic with the arthrimide at the same time, and just assess if we think you're going to get a better outcome.
Okay. We have we have time for one more question. And so with that, we'll go with, what are your thoughts and recommendations in regards to treating the joint with steroids first, then following up with arthrimide, or concurrently injecting arthrimide and steroids at the same time?
Yeah, look, as a CVO, I can't recommend using them both at the same time. To me, it's a little bit counterintuitive because we're trying to get this inflammatory response, allow the gel to integrate. So we could potentially suppress that with corticosteroids. Saying that, there's retrospective data out there. I know there's a prospective study that Bo Whitaker's done in the US showing concurrent use is okay. And what we do know, it doesn't seem to cause an issue, and it doesn't seem to change the outcomes. But I still personally, I think talking to some vets the other day around this as well, you got to take it case by basis, right, and with your owner, because I know that some owners will roam around and they're sort of driving through a district or something. So maybe you get one shot at that horse. So I think if that's the case, then it's probably okay. But for loyal clients in my area, I certainly have got them to the stage now that I'll go to steroids first if I've got a severely inflamed joint, and then I'll follow up 2 weeks later with the 2.5 iPAAG, or I'll go to 2.5 iPAAG first and then consider following up later with corticosteroids. And again, owner pressure around big races, big competition. Sometimes we treat, and I understand the commercial reality of that at the coalface as a veterinarian. So I think, again, I hope for that doctor, some of that explanation I've done around the mechanism of action and how this product's working might help guide them in those individual cases, because I think it is a case by case basis rather than a blanket recommendation.
Thank you, Dr. Lowe, for your experience and expertise tonight, and Dr. Green for your insights as well. We really appreciate it. And for all of you taking the time to attend tonight, we are so grateful for you giving us part of your evening. You will be each sent a copy of this recording, so if there's any parts that you want to go back and rewatch, please feel free to do so. And I know we did not get to everybody's questions tonight, so please reach out to us, and we can try to answer those on an individual basis, because we don't want to leave you hanging, but also want to be respectful of your time. Our next webinar is on October 10th, and so we encourage you to register and attend that one as well. And thank you all for coming tonight. We really appreciate it, and have a wonderful rest of your evening.
Thanks, everybody.
Thank you.